Good afternoon, everyone, and welcome to a celebration of hope, a Kidney Cancer Educational Symposium. I want to thank Dr. Pak and Dr. Manley and the organizing committee for giving me the opportunity to present today. My name is Alice Yu. I'm a urologist at the Moffitt Cancer Center, and I'll be talking to you about the treatment of localized disease in a solitary kidney. I have no relevant disclosures. So to start, what is a solitary kidney? A solitary kidney is a condition in which a person has a single functional kidney instead of two kidneys, and this can happen due to a variety of reasons. For example, some people are born with only one kidney, or they can lose a kidney from a trauma or a cancer. And also people who choose to donate a kidney will also have a solitary kidney. Sometimes people have two kidneys, but only one is functional, and a kidney can lose its function from a variety of reasons as well. This includes recurring kidney infections, kidney stones, renal vascular disease, ureter obstruction, or it could be a congenital etiology. Most of the time, people live normal, healthy lives with one kidney. So what happens when there is a tumor on a kidney? So sometimes we find a small renal mass on the kidney, and this is a solid tumor, typically measuring less than 4 centimeters. We know that these masses are most likely a cancer. About 70 to 80% of the time it is malignant, depending on the size of the tumor. But most of the time these tumors are slow growing. Most of the time we treat these masses as cancer until proven otherwise. However, in select cases, we'll perform a biopsy of the mass, though this is not always necessary before treatment. So a renal mass biopsy is a procedure where we insert a thin needle through the skin to remove a small piece of the kidney tumor that can be examined under the microscope for signs of cancer. This is generally a safe procedure, even in patients with solitary kidneys. The risk of a serious bleed that requires transfusion or embolization is low. And with modern biopsy techniques, we also don't have to worry about the tumor spreading or seeding in the biopsy tract. A renal mass biopsy does have limited clinical utility, though. About 15% of the time, the biopsy can come back as non-diagnostic. And also, if the biopsy is benign, we know that this might not be reliable and it could be a false negative. Therefore, if the treatment is removal or partial removal of the kidney, we typically do not need a biopsy before proceeding. So for the management of a small renal mass on a solitary kidney, the options are essentially partial nephrectomy, thermal ablation, or active surveillance, which is very similar to the management of a small renal mass in people with two kidneys. Partial nephrectomy involves removal of the tumor while preserving the rest of the kidney. This can be performed either with a minimally invasive approach using the robot or through an open flank incision. Robotic surgery is typically associated with less pain and faster recovery. And while there's no contraindications to perform robotic surgery on a solitary kidney, some surgeons may prefer an open approach, particularly if the tumor is in a challenging location. We know that when we operate on a solitary kidney and remove part of the kidney, the renal function will most likely decrease after the surgery. Our surgeons have looked into several ways to minimize the injury to the kidney during surgery, and people have tried various techniques such as using medications like diuretics during the operation, or decreasing the ischemia time, or using ice to freeze the kidney while they operate. Unfortunately, the effectiveness of most of these techniques is limited, and studies have failed to detect a benefit consistently. We do know that the renal function decrease due to surgery is not the same as the decrease seen with medical renal disease. Renal function decrease seen after surgery will typically plateau, meaning that the kidney function will eventually stabilize with time in the absence of any other stressors. With medical renal disease, on the other hand, we see a 5% reduction in kidney function per year, and this is something that is continuous unless there's better medical optimization. Therefore, it is particularly important in patients with kidney masses who undergo surgery with a solitary kidney to have medical optimization. And this means avoiding anti-inflammatories and medications that can injure the kidney and achieving good blood pressure and diabetes control. Typically, we encourage patients to establish care with a nephrologist who can help them achieve these goals. Another treatment option for small renal masses is thermal ablation of the tumor. And this involves inserting a probe into the tumor and delivering some sort of energy to destroy the cancer tissue. This treatment is minimally invasive and generally safe in patients with one kidney. With regards to the impact on kidney function, some studies have found that this is similar to a partial nephrectomy. Active surveillance is another option for management of a small renal mass, and this is an ideal option for patients who are older or with multiple medical conditions and with smaller tumors. We know that surveillance is generally safe and there is a low risk of progressing to metastases, and this can be an ideal option for patients with solitary tumors because there's no impact on renal function. So what if the tumor is too large for a partial nephrectomy? Well, these are challenging clinical cases that should really be discussed in a multidisciplinary tumor board setting. We know that from a cancer control perspective, the gold standard treatment for a large localized renal cell carcinoma is radical nephrectomy because this treatment can be curative. However, in patients with solitary kidneys, they will need to undergo dialysis starting immediately after surgery. Although the safety profile of dialysis has improved considerably over the past decades, there is still serious risk and high costs associated with prolonged dialysis treatment. Therefore, other avenues should be considered. Sometimes we can use neoadjuvant treatment such as immunotherapy to shrink the tumor, allowing for nephron-preserving surgery as an option. And this has been described in the literature, though this is not standardly used. It can be an option in a select subset of patients. Ultimately, these cases should be discussed in a multidisciplinary tumor board setting. So to summarize, in patients with a solitary kidney, if the mass is small, the treatment options include partial nephrectomy, thermal ablation, or active surveillance. Typically, after treatment, we do see a decrease in the renal function, and therefore, to avoid further deterioration of the kidney function, an early consultation with a nephrologist is key. With large tumors that cannot be managed with nephron-sparing surgery, these cases should really be reviewed in a multidisciplinary setting. Thank you for your attention, and I'd be happy to answer any questions.